Let me tell you something about the routine of clinical examination and the videos you're going to watch. A good clinical examination has 3 phases. In phase 1, we obtain the details about the patients, including the presenting symptoms and the detailed medical history. Phase 2 is the physical examination, where we elicit objective physical signs. Both positive and negative signs are equally important. These videos are about physical examination and physical diagnosis. This phase is followed by phase 3, where we explain the diagnosis to the family or the patient as the case may be. Then we come to an informed decision making regarding further management. This will include the necessary investigations and treatment. Many experienced clinicians believe that history and physical examination will yield the diagnosis in the majority of patients. In medicine, we have a very long and rich tradition of clinical examination skills. Some of these signs have been described over a century ago. Some of them have been challenged in this era of evidence-based practice. But surprisingly, most of them have withstood the test of time. Remember, many of these signs were described way before there were ECGs, CAT scans, or MRI scans. The diagnoses were often correct and confirmed by autopsy findings. In these present videos, leading clinician from Newcastle Medical School shows how to examine patients in a valid and systematic way. These videos are based on a system-by-system examination in a traditionally accepted sequence. As you can appreciate, at the bedside, we may need to integrate these to make the patient more comfortable and save our valuable clinical time. Let me give you some examples. We may examine the chest from the respiratory and cardiovascular point, then move down to the abdomen to palpate for a tender liver. If the patient is complaining of lower back pain shooting down the leg, we start with the examination of the back and lower limbs. We do not start with the cranial nerves. Similarly, in a pediatric examination, if the baby is crying, we have to grab the opportunity and look in the throat rather than listen to the heart sounds. However, the main message is to have a system so that important and vital signs are elicited. I think a good clinical examination will settle most clinical issues at the bedside. I strongly believe clinical examination is an art and science. However, please do remember it takes lots of practice to become confident in your clinical skills. These videos do not replace experience of going to see patients and examining them. As Sir William Osler said almost 100 years ago, the facts are locked up in the patients. So go and see the patients to learn medicine. Good luck with your clinical skills.
What we'd like to do is show you how to begin examination with the periphery. And for that we'll ask Andre if he would lie back for us. Bring your bottom to the bend in the bed till you're comfortable. How are you like that? You need something to support your head. I'll ask my colleague to get us a pillow. Now we're going to begin by examining the general appearance of the patient. And as you can see, he's in no distress aside from some situational discomfort. He's not breathless. And we'll begin by looking at the colour of his lips, which are nice and pink. And we'll ask him to stick out his tongue, which is still nice and pink. And we'll notice that he's breathing quite comfortably and slowly without flaring of the nostrils or using the accessory muscles of respiration in the neck. And we'll look at his hands and note that he's not clubbed, that his nail beds are nice and pink, as are the palmar creases. And moving along to the legs, likewise he has good colour, they're warm to the touch. We were looking, as you know, for peripheral cyanosis, or at the tongue and lips, central cyanosis, and clubbing, which is a rare manifestation of chronic heart disease, particularly cyanotic congenital heart disease. Now, having established that the patient is in good shape, we'll move on now to examine the peripheral vasculature, which is often done incorrectly by inexperienced people. So starting at his legs, we're going to begin by identifying the pedal pulses. They're located in the middle of the dorsum of the foot. One presses gently, because if you press too hard, you can feel your own digital pulses. And having located them on both sides, we move on to the posterior tibial pulses, which are just behind the medial malleolus, and coming over, as I am, feeling gently with my fingertips. Now, these are two of the terminal branches of the superficial femoral artery system. The third branch, the common peroneal, can't be felt manually. We go for the popliteals. We need to gently encourage the knee to flex. Let me take it for you, thank you. No, drop it down, good. And with two fingers, one on either side, I push in posteriorly and feel the popliteal pulses. They're all present. I can now move on to the femorals. Now, in the interests of patient's dignity, I won't expose him for you, but I will tell you where you find them. The trick is to find the anterior superior iliac spine, drop one's hands down, and with the thumb, feel the greater trochanter of the femur. And at that level, you'll find the inguinal ligament in the groin and the femoral pulse just below my hand. Now, in the upper limb, one feels the radial, and one can feel the ulnar pulse. Yep, I've got it. And the brachial is easiest felt in the forearm, on the medial aspect of the flexion crease. One can also feel the brachial up here in the upper arm, but this is a little more difficult. In his case, I've got it quite easily. And for the axillary, we have to get intimate. We open up the arm, we warn the patient what we're going to do. I'm coming into your armpit. We pop a hand just deep, and the pulse is right there. Now, more proximal to the axillary artery is the subclavian. The subclavian we can't feel, but we can hear. If the subclavian is stenosed, you will hear a bruit in the proximal portion of the subclavian between the medial insertion of the clavicle, the sternoclavicular joint, the medial third and outer 2/3 of the clavicle is where the subclavian gives rise to the vertebral artery. This is the first place that the subclavian is accessible outside of the thoracic inlet, and the vertebral arises at this location. So, to listen for bruits, one takes out one's Mickey Mouse stethoscope and uses the bell. And very gently hold it in place. And when you do this, you'll often hear the patient breathing. If the breath sounds get in the way, you simply say, "Andre, would you please take a big breath in, hold it there. Thank you." And please note that while I ask him to breath hold, I breath hold. For most of the patients who are breathless at rest, by the time you think you're a little bit uncomfortable, they're bursting. So, seeing we're on bruits, I'll show you how we locate the carotids. Now, for that, could you please pop your head back for me? Now, the carotid pulse is felt here. This is the common carotid. But that's not where you listen for bruits. Bruits arise from the internal carotid. The bifurcation is just at the angle of the jaw. So again, one takes the bell, locates it just at the angle of the jaw, and asks for a breath in, hold it there, and listens carefully. Thank you. We'll do the same on the other side just for completeness. First the subclavian and vertebral origin, and next the carotid. Now, we're ready to move on to blood pressure examination. And this, in the modern technology era, is often skimmed over with potential for great error. When we were dealing with blood pressures of 200, a 10-point difference made little difference. But these days, when 140 rings alarm bells, you'd like to be sure that you're not dealing with 130s. And the trick to blood pressure examination is follow the instructions. Here I have a cuff. And on the cuff, you'll see the word arteria, which is Italian for vein. The artery needs to be in the middle of the cuff so that you get a proper occlusion from your cuff. Too often do we see people popping on the blood pressure cuff with the middle of the cuff situated out laterally. The effect of this is you need a much higher pressure in your sphig to actually occlude the artery. So the trick is you place the cuff over the artery and you take the time to carefully place the belt for a nice good seal. And if it's popping, you're not going to get an accurate pressure. Get yourself a bigger cuff. Now we pop the arm down. In his case, we'll let him rest it at the side. And we begin by palpation. I've got the brachial. Whoops, I need to open his elbow to get it on this occasion. And first we go by palpation. So I pump the cuff up until the pulse disappears. And I wait as I let the cuff down. And I look at see what pressure the blood pressure, the pulse becomes palpable. That's the more or less systolic pressure. The reason one does that is there is very rarely what's called an auscultatory gap, where you hear the sounds at the true pressure, then they disappear for a while, only to reappear at a false systolic pressure. Now, we want to be sure that's not happening, so we always begin at the palpation pressure and above. And this time, I take my diaphragm so I can get a nice good seal, and slowly letting the cuff down, I wait until I can just hear the sounds. That's my systolic pressure. And as I approach diastolic, I'm listening for a muffling of the sounds. I'd better shut up if I want to hear them. There it is. That is Korotkov phase 4, which is the recorded diastolic pressure. When the sounds actually disappear, we call Korotkov phase 5, but you don't want to use that because it can be as low as 0. The true diastolic pressure is the one where the sounds muffle, if you want to be accurate. Now, how would we examine for pulsus paradoxus? Remember, in pulsus paradoxus, we're looking for a difference between the systolic blood pressure during inspiration and in expiration. Now, we're not going to get him to breathe in, breathe out while we take the blood pressure. We're going to just let him breathe quietly and not let on what we're doing. Okay, Andre, you don't know what we're doing. There we go. So the first thing I do is I go above the palpation pressure again, and I start listening, and I let down very slowly, because what I'm waiting for is when I hear 1 or 2 beats. Yes, there's a beat. No, it's gone. Yes, it's back again. He must have breathed out. And I look at that pressure, and then I come down until I hear every beat. Ah, there it is. And the difference between those two pressures should be less than 10 millimeters of mercury, because it's normal to have some respiratory variation in your systolic pressure, which is what pulsus paradoxus is all about. When it is excessive variation, it's abnormal. Well, that's the end of blood pressure. So it's time now to get on to examine the heart. After all, that's what we're here for. Now, examination of the heart requires that you expose the patient properly. Again, in the interests of dignity, we've asked this man to take most of his clothes off. If he were a woman, then we would be using a sheet. And it's quite possible to expose the patient properly, cover it up with a sheet, and then expose as required, and then cover up again. If you don't take the clothes off, you're going to make mistakes some of the time. Now, how do we examine the heart? Well, the first thing is we must locate the apex beat. Now, the apex beat is usually found just under the nipple. I might have to lift up his breast, and sometimes it'll be visible. In his case, I can sort of almost see it over there. But when in doubt, you feel gently. Don't push too hard. You're feeling with the flat of your hand. You might need to use your fingertips if that doesn't bring it on. And if you can't find it, you say, would you roll over onto the left, please? And as he rolls, you get your hand under there, and that brings the heart nearer to your hand as it falls against the rib cage, and I've got it for sure. And now by rolling him back to your original position, thank you, I've managed to keep my finger on it and not lose it. Now, where is it? There it is. How do we describe it? Well, we have to count interspaces. So we begin, would you pop your chin up for me just to make it easier? We feel between the ribs for the first interspace. Now, the first one you can feel is the second interspace. Then you go down 3, 4, 5, and you'll see he's in the fifth interspace. And chin up if you would. Mid-clavicle is about there, and he's just in the mid-clavicular line, give or take a half a centimeter's error. This is the normal heart position. As the left ventricle enlarges, you'll find that this moves down and out. So it'll hit the sixth interspace and the anterior axillary line, the seventh and the mid-axillary. Now, having located the apex beat, determined that the heart's not enlarged, we'll now see if there are any abnormal pulsations or sensations, and particularly we'll start with the right ventricle. The right ventricle is situated right in the middle of the chest, on the left-hand side of the sternum, and you need a very gentle hand. What we're looking for is a tapping feeling at the bottom of my hand. In the pulmonary area, this is where you might feel pulmonary valve closure in pulmonary hypertension. The aortic area, you generally don't feel an aortic closure, but you may feel a thrill. So I can pop my hands on and say, no thrill. However, look at the problem that my aortic valve is not up against the chest wall. If I really want to feel an aortic valve thrill, I've got to say, would you sit up, please? And can you lean forward, just as before, and have a big breath in and out, and hold it there. And now, without much lung between hand and valve, are you bursting yet? You can breathe. No thrill palpable. One might feel above the neck in the same technique. Have a gentle breath in, out, hold it there. I'm not choking the patient. I'm trying not to choke the patient. Again, sometimes the thrill will be felt just in the suprasternal area. Now, having examined for aortic valve thrill, palpable pulmonary closure, abnormal right ventricular impulse, and apex beat, we're ready to examine the venous pressure. Back you go, my friend. Now, for standardization, we're going to show you the patient at 45 degrees. And what we're looking for is a flicker in the root of the neck, which may or may not be visible. And in his case, I really can't see one. Now, what's special about 45 degrees? Nothing, except that at 45 degrees, it can be normal to just see a flicker at the root of the neck. Now, please note what I don't do. I don't push on the neck to try and make a column appear, because even though I make several columns appear, these are in the external jugular system. These are not the internal jugular. One can't rely on the external jugular because it has a tortuous course on the route, en route through the thoracic inlet and may have valves. Instead, what I'm trying to do is enhance the internal jugular, and to do that I use abdominal pressure. Now, I don't just poke my hand in as much as I might be tempted. I warn the patient what I'm going to do. I'm going to push on your tummy. Would you please just breathe normally, don't hold your breath. As I push, increasing the intra-abdominal pressure, I really still can't see the venous pressure, not convincingly anyway. So I slowly let go, and we might try and do that again. Now, before we change his position, I might just show you the effect of respiration on his venous pressure and what not to do. If you focus on his neck for me, Greg. Now, Andre, would you please take a big breath in? Go. And out. In again. Out. Well, he didn't do what I thought he would. Perhaps you could look at my neck and I'll show you. Usually when you say to somebody, take a big breath in, this is what you get. And you see the platysma muscle just overlies everything. And you can't possibly see the venous column when they do that. But in his case, because he's so well trained, he knew that a big breath in meant take a long, slow, deep breath in without using your accessory muscles. But as it happens, we did see the venous pressure when he did that for us, just at the end of inspiration. I'll get him to breathe in again, and this time when he breathes in, you won't see the venous pressure until he's at the end of inspiration. And then in the terminal bits, when he's actually holding his breath, the venous pressure starts to appear. So perhaps you could do that again for me, Andre. A nice, slow, deep breath in, and there it comes. And breathe away. Okie dokie. Now, to enhance this venous pressure and to confirm that it is in fact normal, we're going to lie him down. So would you please sit up for me? Down goes the bed, complete with creak. And thank you. If you could lift your chin for me and turn it to the side. Again, we're looking for a flicker at the root of the neck. Now I see a pulsation here, but I'm not sure if it's arterial or venous. An arterial pulsation has one component, a venous has multiple. So, again, I don't try and push on it. I don't fiddle except to increase abdominal pressure. My hands are on your belly, and I'm going to push gently, so would you please breathe normally? And you'll see when I do that, the column becomes more noticeable, particularly here in the external system. You can use it if it's clearly flickering. And when I let go, the external still looks full, so you can see how misleading that can be. All right, we'll try for your internal again. Now I can sort of almost see a pressure, a flicker at the root of the neck. Perhaps you could take one of those long, slow, deep breaths in for me again. And he's holding his breath. I can't see a venous pressure. You can let it go, thank you. One more time, I'm going to push on his tummy and see if a venous pressure appears. Maybe just at the root of the neck now. I am not convinced that I've been able to see his venous pressure at all, and rather than say venous pressure normal, on this occasion I will say venous pressure difficult to be sure. In fact, venous pressure probably normal. Please, would you sit up for me again? And let's pop your legs over the side of the bed. Chin up for me. Now at 90 degrees, the venous pressure should never be seen. And seeing we couldn't see it at 0 and 45 degrees for sure, it's important to sit the patient up just in case it was very high in the first instance and it now would have come down into view. We're having some difficulty with getting the light. We're perhaps on the wrong side of the bed, but I'm quite happy that this venous pressure in his case is quite normal. We will have a patient in which we can show you the venous pressure in a moment. Now, perhaps you could lie down again for me. I'll just put your bed back up because we're ready to get on to auscultation. lie down a little, make yourself comfortable. Thank you. Now, auscultation. In the era of electronics, you can get yourself an enhanced stethoscope which will download. When you overcome the technology, you'll have a lot of interference, and my advice to you is develop ears, because that's your weakest link. Get the wax out, get a stethoscope where they fit comfortably. Imagine I'm in business class on an aircraft and trying to get a nap. Now, with a comfortable stethoscope, I'll show you how I auscultate, and everybody has differences. The first trick is you need to get your timing right. So I feel the carotid, because I want to know when is systole happening. The first sound will be before the carotid and the second after. Don't feel at the periphery, because there's a delay. In fact, I'll be out of phase. I might get systole and diastole totally mixed up if I go to the radial or even the brachial pulse. So with a hand on the carotid, I now start listening in the aortic area. Now, the reason I listen in the aortic area is because when I listen at the apex, I often hear and it's too fast, too much happening. I listen at the aortic area where I usually can't hear the first sound at all. And all I can usually hear in this area is the aortic sound. With my diaphragm, I feel his carotid, I hear boom, 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 and that timing of that second sound gives me the aortic. And I move now toward the pulmonary area, always keeping that aortic closure sound in my ears. I go to the pulmonary area, and here only I might hear two components to that second sound. And I'm interested in the effective respiration. But if I ask him to have a big breath in, please, Andre, all I can hear, stop, everything disappears. The heart's moved away from the chest wall. You can breathe. So if I want the effective respiration, I'm going to have to sit him up again. Now that I've got two components of the second sound, and I've satisfied myself that there are two, and that they move or don't move with respiration, I can now move down to the tricuspid area and the apex. I'm hearing the first sound very well now, as well as the second, even though the theory is that I should have to change to the bell in order to hear the first sound. That's often not the case. The first sound is usually easily heard with the diaphragm, it's just better heard with the bell. Now I move over to the apex, listening for extra sounds, and at last I'm at the apex. I'm in the area where we might listen for mitral valve murmurs. Now, if I want to hear a mitral valve murmur, I must roll him onto the left. Would you roll over onto the left, please? Thank you. And I bring the heart much closer to the stethoscope, and I use the bell, and I press very gently, and I get my hand back on the carotid if I've lost my timing. And I listen during quiet respiration. And what I'm listening for is a low-pitched murmur in diastole for mitral stenosis. Or for mitral incompetence, a much more common murmur, I'll be using my diaphragm, and I'll be following a murmur out toward the axilla or back towards the left sternal edge, or even the aortic area, trying to determine where it's loudest. Before I leave the apex again with my bell, if I think I hear a third or a fourth sound, I'll push hard with my bell, and if it muffles, there's a good chance it was indeed an extra sound, a gallop. If I can't hear it muffle, I won't be sure, was it a split sound, a click, or whatever. Now, would you roll back straight for me? And would you please sit up? Now, for aortic valve murmurs, it's important to begin in the aortic area. And if I want to decide if it's louder or softer with respiration, I let him breathe quietly. because if I ask him to have a big breath in, all the sounds are going to disappear again. Big breath in, please. Can't hear a thing. And out. Hold it there. Now I can. And this is the best way to listen for aortic valve incompetence. With the diaphragm pushed hard up against the sternum in the aortic area and the second left interspace. You can breathe now, thank you. During held expiration. Because the aorta runs from the ventricle into an arch, the valve closure often radiates down towards the left sternal edge. Now, pulmonary valve incompetence, tricuspid incompetence, much more difficult. For pulmonary incompetence, you might really not be able to tell the difference from aortic, except perhaps this radiation pattern coming this way rather than that way. Too hard for most of us. For tricuspid incompetence, you might hear a systolic murmur at the lower sternal edge that increases with inspiration, but by far the best way to make that diagnosis is from the pattern of the jugular venous pressure. Now, just for completeness, I'll listen to the lung bases to make sure that they are not congested. Would you have a nice big breath in for me, and out, and again, and out. As chest examination goes, that's hopelessly inadequate. However, a separate module will be examining the respiratory system for you. Now, what about aortic stenosis? This is a common murmur, and it's important that we examine for it properly. Again, although this is the aortic area, the aortic murmur might be loudest at the apex. And it's important to be honest with yourself about where you can hear it. If it radiates to the axilla, it's almost certainly mitral incompetence, whereas aortic murmurs will tend to radiate to the neck. Now, again, we listen in the aortic area and we hear a murmur. We don't try to describe its character, that's too hard for us today. We go towards the apex. We hear it getting softer. Once we're trying to listen in the neck, and I put my diaphragm up there, straight away I don't have a good occlusion, and I might miss it. So it's important, I think, to change to the bell, which will fit in the little gaps in the neck much more easily. And I'll hear the murmur as it radiates up towards the carotids, getting softer as I go. The same on the other side. If the murmur seems to be louder, be careful, I might be dealing with an associated carotid bruit. And remember also to please sit up and sit forward and have a big breath in and out and hold it there. And just like aortic regurgitation will be enhanced in expiration, so will aortic stenosis. Now finally, what about the pulsatile liver of tricuspid incompetence? Now this is a difficult one. It's difficult because it's very subjective. One has to have very soft hands and one must be careful of a pulsatile abdominal aorta. What I do is I first establish if the liver is enlarged and tender. But that doesn't tell me if it's pulsatile or not. For pulsatile, all I want is a couple of fingers below the costal margin, very gently. Big breath in, hold it there, and out. Some people say that it's easier if you sit the patient up, put your hands over the liver from the back. In this case, Andre has tensed his abdominal musculature and it's made it a lot harder. Gentle breath in, hold it there, and his liver's not pulsating. I think you're going to survive until tomorrow.
Jonathan, when do you examine for radiofemoral delay and what's the significance of that?
Well, radiofemoral delay is found in aortic coarctation. Although patients with aortic dissection often have diminished femoral pulses, they are not delayed. You suspect aortic coarctation in anybody with hypertension at a young age, and the technique is to feel and find the radial, feel and find the femoral. Now remember again, anterior spine, greater trochanter, across I come. Aha, I've got the femoral pulse. Now I take the radial, And if they're coming at the same time, there's no delay. There are circumstances in which one will look for radiofemoral delay even if the coarctation is not suspected, but I've yet to encounter what those are. As far as I'm aware, it's a specific sign for aortic coarctation, and recoarctation in patients who've had a previous repair, the radiofemoral delay will go, but if they restenose, it will reappear.
Thank you.
While we're on the assessment of unusual causes of hypertension, we should perhaps show how to examine for a renal bruit.
Sure.
Would you lean back for me, my friend? Thank you. Now, this is not how to listen for a renal bruit. The patient has to be flat. Could you sit up? And back we go. There you go. Now, the renal arteries arise about 2 centimeters above the umbilicus. They're rising in a paired fashion from the aorta. And again, we'll listen with our diaphragm. We will warm the patient. I'm going to push on your tummy and apply very gentle pressure. I'm looking for a good, firm seal as I get close to the abdominal aorta. And if necessary, I'll ask him to breathe in, out, hold it there. I'm breath holding with him. You can breathe. If I hear a bruit, I'll try and follow it out towards the flanks to confirm that it is indeed arising from the renal arteries. Remember that the mesenteric vessels, the SMA and the celiac axis arise there as well as abdominal aortic disease can give rise to a bruit in that location.
So when do we examine for edema and where do we look for edema?
Well, edema is an important sign in heart disease, particularly as a sign of heart failure. But as you know, edema can also be due to renal disease and nephrotic syndrome, an important comorbidity in patients having a cardiac assessment. Now, dependent edema is maximal toward the ankles and declines as you move up the shin. It's always easiest to press on the shin with your thumb, but if you start too high, you'll miss a mild case of edema. I usually start just above the ankle and some good firm pressure with my thumb, not enough to hurt the patient, I hope, letting go and looking for pitting. If in doubt, feel along, you'll see if pitting was present. If there's no edema in this location, it's probably not present, although the earliest place where edema appears is behind the medial malleolus, and this has to do with the venous distribution. You need some firm pressure sustained for at least 5 seconds in most cases. Now, if there's no dependent edema, consider the patient might have been lying in bed, in which case the dependent areas are the sacrum. So I'll ask you to sit up, please, Andre, and we'll come around, Greg, if you don't mind. This is the one chance I get to sit on the bed and rest my weary legs. Again, gentle pressure at the lower lumbar spine above the sacrum. Release, no edema present. And now we'd like to move on to examine the venous pressure in a real patient. We're very grateful to Mrs. Smith, who's given us her time so that you can see her rather unusual jugular venous pressure. To start, would you sit over the edge of the bed for us? And you'll see we're going to sit at 90 degrees. You'll see there's nothing special about 45 degrees. Now, Mrs. Smith, if I could ask you to hold your chin straight for me, and we'll allow the camera to come in and focus on the pulsation here in the root of the neck. Now, if you look at this pulsation, you'll see a visible column that seems to be moving up and down. This has the characteristics of a venous pulsation because there's more than one flicker. It goes 1, 2, 3, 1, 2, 3, 1, 2, 3. Now, how high is it? Once she's sitting, as she is, at 90 degrees. Greg, if I could ask you to pan out slightly. What we're looking at is it's the height of this column relative to the position of the right atrium. Now, at 0 degrees, when lying flat, the right atrium is here at the level of the anterior axillary line. At 45 degrees, It's here at the level of the sternal angle. At 90 degrees, I've never been able to determine exactly the position of the right atrium. I use the sternal angle for reference. Now, with that as 0, I measure how many fingers. Indeed, I get 5 fat little fingers above the sternal angle. And because I've measured them previously, I know that that's about 8 centimeters of water, the height of this venous column. So I could report this as the venous pressure is raised 8 centimeters relative to the sternal angle. Now what we'd like to do is look at the behavior of this venous flicker when we change her position. Would you mind leaning back for me? Bring your bottom back to the bend in the bed, and you'll see we have the bed at 45 degrees, but with the pillow it's possible to bring the patient a little bit higher, which is not desirable. 45 degrees is again a reference angle. There's nothing special about it. Let's look at this venous pressure now, and you'll see that relative to its position in the neck, the flicker has moved upwards. You can see it higher above the sternomastoid muscle than it was before. And if you'll allow me, I'll just gently apply abdominal pressure. So Mrs. Smith, if you'll just breathe normally, I'll be pushing on your tummy. And I push nice and gently, and you'll see how the venous pressure goes up in the neck relative to where it was before. And that is normal. However, it should come down within a few beats. And in her case, it stays up until I let my hand go, and you'll see the venous pressure moves down the neck. If I were to try and estimate its height again, I'd go to the sternal angle and 1 fat finger, and it would still be around about 8 centimeters relative to the sternal angle at 45 degrees. Now what we'll do is show you what happens if we lie her flat. And to do that, would you sit up for me? I'm going to take the bed down. Whoops. Needs some 3-in-1 oil. And now if you'd lie down again, get comfortable. Perhaps you take yourself down the bed a little. Thank you. And could you lift up your chin for me? And now when we look for the venous column, we can barely see it. Just the bottom of the venous flicker is seen at the angle of the jaw. And that's because this column has disappeared through her jugular foramen and all the way up into the skull cavity. Thank you, Greg. If I could ask you to move out again, and Mrs. Smith, if you'd sit up for me. We're going back over the side of the bed. I examine at 90 degrees because it's more comfortable for the patient, and I'm never in doubt that the venous pressure is raised if I can see it at 90 degrees. If you have the patient at 45 degrees, it can be normal to see the venous pressure just here at the root of the neck. However, at 90 degrees, it's always abnormal to see the venous pressure like this. Now, we'd like to show you a special feature of this JVP. Greg, if I could ask you to come in slightly and very gently turn your head my way so we have better light. Thank you. Now what we're going to do is look at the effect of respiration on this venous column. Would you have a nice gentle breath in for me and keep it coming in? Thank you. And breathe out. And now let's watch again as she takes a nice, slow, deep breath in, all the way, keep it coming, and breathe out again. Now there's no doubt that the venous pressure is rising on inspiration. This is not normal. Often if you get the patient to breathe in deep and then hold their breath, at the end of the breath, the venous pressure will appear to rise. But in her case, this venous pressure goes up immediately. This is a very rare finding. You won't see it very often. It's known as Kussmaul's sign, but it refers to abnormal physiology and the inability to accommodate a returning volume without an increase in pressure, as you see when the myocardium itself is restricted or the pericardium around the heart is constrictive. I thank you, Mrs. Smith. You've been most kind for your time.